Hello everyone, this is Dr. Pritpal Singh, an MD Pharmacology from CMC Ludhiana, and today I'll be talking about the competency PH 1.14, which talks about describe the mechanism of action, doses, types, side effects, indication, contraindications of cholinergic and anticholinergic drugs. Though I have covered my cholinergic session of cholinergic drugs in two of my sessions previously, out here I'd be talking about the anticholinergic drugs. Now, when we are talking about anticholinergic drugs, today I would be focusing on muscarinic antagonist only, whereas in due course of time, we'll also be talking about the nicotinic antagonists such as the ganglion blockers and the skeletal muscle relaxants. So at the end of the session, if you feel you have any queries or you want to ask something, you can write down on the chat box and I'll definitely get back to you. So I hope I'm able to clear some air on this particular topic, and this is as per the new CBME curriculum, which was given by NMC in the year 2019. So we start with the cholinesterase blocking drugs or anticholinergic drugs. Now these drugs have been divided into muscarinic and nicotinic subgroup. Now, if we go back to the section on cholinergic, we said that cholinergic acetylcholine binds to two types of receptors, the nicotinic receptors and the muscarinic receptors. So, drug acting on the muscarinic receptor and increasing its activity is an agonist, whereas drug inhibiting the activity of an agonist is an antagonist. So, out here we are talking about the muscarinic antagonist and the nicotinic antagonist. As highlighted earlier, the nicotinic antagonist drugs are the ganglion blockers and the neuromuscular junction blockers, whereas the muscarinic antagonists are mainly the parasympathetic drugs, which are also known as anti-muscarinic drugs or muscarinic antagonist, and atropine is the prototype of this particular group. Now, when we talk about the source and chemistry of this particular group of drugs, let's say we talk about atropine. Atropine is a wild plant that is commonly found in India with the name of thorn apple or datura. And the scientific name of this particular vine plant is Atropa belladonna or datura stramonium. Now, this is basically a tertiary amine alkaloid which is a racemic mixture of D and L hyoscyamine, which is the active component in this particular compound. Another compound that is also a natural derivative is copolamine, which is obtained from the plant Hyoscamus niger, which is an L isomer. Generally, the L isomer is more potent, and this is what mainly governs the semi-synthetic and synthetic preparations, and it is around 1000 times more potent as compared to the D isomer. Apart from these particular drugs, there are few more classes of drugs which, although do not belong to the category of muscarinic antagonist, but they do somehow display the property of muscarinic antagonist by blocking the receptors and acting on a different particular type of disease. Some of these drugs which we commonly encounter or which we commonly study are the antihistaminic drugs, the antipsychotic drugs, and the antidepressant drugs, where we talk about the anti-muscarinic effects or anticholinergic effects of these drugs, which are depicted as uh, dry eyes, dry mouth, urinary hesitancy, and constipation. Now, when we come to the classification of this particular group of drugs, that is the muscarinic antagonist or the parasympatholytics. Now, these particular drugs are divided into natural alkaloids, semi-synthetic derivatives, and synthetic derivatives. The natural alkaloids we have been talking about, a racemic mixture of D and L isomer is atropine, whereas L isomer is hyoscine. The semi-synthetic derivatives include atropine methonitrate, hometropine, hyoscine butyl bromide, ipratropium bromide, and tiotropium bromide. Coming to the synthetic derivatives, which is mainly the active form, this is further subdivided into four categories: the anti-secretory, antispasmodic, the mydriatics, the vesicoselective, and anti-Parkinsonian drugs. If we want to restrict ourselves to the mydriatics, then we have two drugs that belong to this particular category, that is the cyclopentolate and propicamide. And atropine obviously is used in infants and children for mydriasis. Then we coming to the vesicoselective drug, which have a more specific action on the urinary bladder. We have oxybutynin, flavoxate, doltarodin, derifenacin, and solifenacin. Coming to the next category of drug, that is the anti-Parkinsonian drugs, we have trihexyphenidyl, procyclidine, and piperidine. And when we come to the anti-secretory spasmodic, they are further subdivided into quaternary compounds and tertiary amines. The quaternary compounds are have limited lipid solubility. The examples of this particular group being propenthyline, oxyphenonium, clidinium, simetropium bromide, isopropamide, and glycopyrrolate. Whereas when we talk about the tertiary amine, we have dicyclomine, weltamate, and pyrazipine, which are exclusively tertiary amines. Moving beyond this, now when we talk about the further properties of these particular group of drugs, we talk about their pharmacokinetic and pharmacodynamic variables. So starting with the pharmacokinetic variables, we talk about these in the category of absorption, distribution, metabolism, and excretion. So when we are talking about absorption, these particular drugs are either natural alkaloids or tertiary amine or quaternary amine, and depending upon the nature of their particular compound, they could be well absorbed or highly lipid soluble, and some of them like quaternary ammonium compounds have limited lipid solubility, so their absorption is somewhere around 10 to 30% when they are given through the gut, whereas the natural alkaloids can even be absorbed through the skin. Now, again, this property further determines their distribution. Now, this distribution could be, again, depending upon whether it is a lipid soluble or non-lipid soluble. A lipid soluble compound is widely distributed and can produce a CNS effect in 30 minutes to 1 hour. Scopolamine is another compound that is totally distributed to the CNS, whereas quaternary compounds which have low limited or limited lipid solubility have limited distribution in the CNS. Talking about the metabolism and excretion, these drugs are rapidly excreted through the kidney with a T-half of 2 hours, and the rest in urine and as hydrolysis product or conjugated products, and it rapidly declines in almost all the organs except eye. Specifically, it stays in the eye for around 7 days. Coming to the mechanism of action of this particular drug. Now, when we talk about the mechanism of action, the mechanism of action would depend upon what basically this particular group belongs to. This particular group is a muscarinic antagonist. That means that these drugs will bind to the muscarinic receptors, namely the M1 receptors, the M2 receptors, and M3 receptors, and would block them. Now, the type of blockade of this particular receptor is the reversible blockade. Now, if you go back to where M1, M2, and M3 receptors are, M1 receptors and M3 receptors tend to activate the adenyl cyclase C, whereas M2 receptors act on adenyl cyclase C. That is how these particular drugs will act on a reversible basis on these particular receptors, and their effect would vary depending upon what is the tissue involved and what is the source of agonist. Now, depending upon the tissue involved, the most sensitive tissue is the salivary glands, the bronchial glands, and the sweat gland, and the least sensitive tissue is the gastric cell of the stomach. Now, talking about some other group of drugs, the exogenous muscarinic antagonists are more effective, and their selectivity will depend upon the various subgroups that we have already talked about as vitriatic, anti-spasmodic, anti-secretory, vesicoselective, and anti-Parkinsonian. Now, coming to the organ system effect, again, we are talking about atropine as a prototype. So, when we talk about atropine at the recommended doses or at the doses in which it is used, it causes minimal CNS effect. Now, compare it with vis-a-vis with scopolamine, which has more rapid, more action on the, or is more easily it enters the CNS. So, it has more effect on the CNS, and it leads to drowsiness, to amnesia, and if supposedly there's a toxic dose, which is always a possibility, it could lead to excitation, agitation, hallucination, and coma. When we talk about this particular group of drugs in cases of Parkinsonism, this particular drug is one of the parts of the polypharmacy, and it tends to reduce tremor that is associated with Parkinson's disease. This particular drug is also effective in vestibular disturbances, acting on the muscarinic receptors, and is quite effective drug for motion sickness. Moving further beyond the conventional organ system effect, we move to the eye. Now, in the eye, it causes the mydriasis, opposite action of semiosis, which is caused by acetyl choline. Now, this is why this happens, because it acts upon there is an unopposed, it blocks this pupillary constrictor muscles. So there is an unopposed action on the sympathetic dilator activity, leading to mydriasis. It also tends to cause weakness of contraction of ciliary muscles, causing cycloplegia, which leads to blurred of vision, which is one of the common adverse effect associated with atropine and other drugs or anticholinergic drugs. It also causes dry eye because it tends to lead to reduction in lacrimal secretion. Now, coming to the respiratory system, we can divide it into two components, acting on the bronchus, acting on the mucus glands. In the bronchus tree, it causes bronchodilation, which is limited, whereas it tends to significantly reduce the secretions in the mucus gland. So if it is reducing the secretion in mucous glands, it is used as an anti-secretory, which can be used prior to general anesthetic. Now, why is this particular drug not an effective bronchodilator? Now, this is because its effectiveness is limited as block of autoinhibitory M2 opposes bronchodilation, which is by block of M3 receptors. Acting on the CVS. On the CVS, it acts on the sinoatrial node, and we talk about acetylcholine causes bradycardia, so this causes blockade of vagal slowing, which can lead to tachycardia, though there is a chances of initial bradycardia. Now, this initial bradycardia could be or is explained on the basis of its presynaptic muscarinic receptor block, which is on vagal postganglionic fibers. It also causes reduction of PR interval by blocking the AV node. In the vessels, it tends to dilate the coronary arteries, and the sympathetic cholinergic nerve cause vasodilatation is also blocked. It prevents the cardiovascular effect of administered direct acting muscarinic stimulants. In the GIT, it causes decrease in secretion. It decreases the secretion of the exocrine gland, leading to dry mouth, decrease in the gastric acid secretion. Now, this decrease in gastric acid secretion is in the amount of both volume and amount of acid, pepsin, and mucin. The basal secretion is also decreased, but this is more effective with pyranzapine and talanzapine. The tone and propulsive movement also tends to decrease, so this causes a prolonged gastric emptying and intestinal transit time. In the genitourinary tract, it tends to relax the smooth muscles of the ureter, the bladder, and slows voiding for treatment of spasm that is generally accompanied by inflammation or surgery. In the sweat gland, it tends to suppress the thermoregulatory sweating, leading to atropine fever. So based upon all the pharmacological actions that we have discussed so far, let's talk about the therapeutic applications of this particular drug. So again, when we talk about the therapeutic applications, we tend to talk about its action in the CNS. So in the CNS, if we go by the classification, the first action was as an anti-Parkinsonian drug. It is quite effective in reducing the tremors. So this is one of the drugs that is commonly given in Parkinsonism as a part of polypharmacy. We also talked about this particular drug, scopolamine, acting on the vestibular cells, thereby reducing motion sickness. So this drug is quite effective in seasickness. Specifically, we are talking about scopolamine, and this drug could be given by injection, it could be given perorally, or it could be given by the transdermal therapeutic system. In the eyes, it is often given to uncooperative patients so that an accurate measurement of refractive error can be done. It also helps in examination of retina. And this particular drug is basically not used unless we require mydriasis for a long duration of time. And it can be combined with meiotic drugs so that synapse formation is prevented in cases of uveitis and iritis. In the respiratory disorder, we have already talked about this. This particular drug acts as a pre-anesthetic medication. Now, because why is this required? Because ether was an irritant which tend to increase secretion. So this particular drug decreases secretion. It also leads to an amount of asthma, and it tends to cause hyperactive neural bronchoconstrictor reflex, which can be blocked by epotropium. And this, the basic advantage is that it could be given through the aerosol. It is also used in coronary artery, chronic obstructive pulmonary disease. In the cardiovascular disorder, this particular drug could be used for depressed sinoatrial node or AV node following acute myocardial infarction in hyperactive carotid sinus reflex. It could also be used in idiopathic dilated cardiomyopathy, where we have the circulating antibodies and there are parasympathogenic action. In the GIT, it could lead to traveler. It could be used in traveler diarrhea, in hypermotility disorders, and in peptic ulcer. In the urinary disorder, this particular drug could cause symptomatic relief in urinary urgency. Oxybutynin is used for these purposes, and now tolterodine is also being used. Apart from this, this particular drug can also be used for as an antidote in cases of organophosphate or carbamate poisoning. Now, this particular drug is given after every 5 to 10 minutes till reversal of meiosis occur. And if the patient comes at an appropriate time, it could be combined with cholinesterase regenerator compounds, which are oxime derivatives. They could be palidoxim, or they could be diacetyl monooxim, which is useful or beneficial for organophosphate poisoning, though their efficacy or their utility in cases of carbamate poisoning is limited. Apart from this, it could also be used in hyperhidrosis because it tends to decrease the secretions of the lacrimal gland. Talking about its adverse effects, now one thing that we always talk about when we say adverse effects, that is that this particular drug, the adverse effects are an extension of the pharmacological action. So what are the pharmacological actions out here? The pharmacological actions out here are that it causes mydriasis and cycloplegia. So at high doses, it could lead to blurred vision. In case of poisoning, it could lead to dry mouth, mydriasis, tachycardia, hot and flushed skin, agitation, delirium, elevated body temperature. Treatment is symptomatic. There are certain contraindications to this particular drug. These contraindications include glaucoma, history of prostatic hyperplasia, and acid peptic disorder. So this is all about the cholinergic drugs. I hope I have been able to clear some doubt on this. And if there's any queries, do let me know. Till that time, happy learning and have a nice day ahead. Thank you so much for your patient hearing.